Thank you for this opportunity to quite shortly tell you something about how we are working with a strategy for digitalization of the health and care sector in Norway. It's a bit early in the morning for me, so I'm sorry if I'm stuttering a bit in my English, but I try to slowly take you through some few examples. But I would like to, first of all, tell you short about Norway, since I'm the only one from the European countries here. Norway is a monarchy. We had our constitution in 1814 and only got our independence from Sweden, our neighboring country, in 1905. At the moment, we have our government is a coalition of two parties, and we have about 15 regions and 357 municipalities, and really a large variation in the size of the municipalities. From Oslo, which is the biggest one and our capital with 500,000 people, but about 60% of our municipalities has less than 10,000 people. So it's a large variation in the size, and 8 out of 10 people in Norway live in urban areas. And as a lot of other countries, we also have aging population, especially in the rural areas. We also know that the pressure on our health and care services will increase because of our demographic development. And this is perhaps the main reason that we need to focus on digitalization, e-health and welfare technology. This is to increase our service capacity in order to be able to continue giving adequate services of good quality to those in need of them also in the future. What you see now gives you an overall picture of Norway. We have universal health coverage in Norway. And in 2018, Norway was among the top 10 countries in the world in life expectancy. This according to the OECD. Our life expectancy is 81.6 years for newborn boys and 84.7 for newborn girls. And we have about 5.4 million people. They are spread about 400,000 square kilometers, meaning that Norway is one of the most sparsely populated countries in Europe. And for those knowing Europe, if you put your finger in Oslo, that is down south in Norway, and turn the country upside down, you end up in Rome in Italy. So it's a quite long country and a lot of mountains and fjords and islands. So to give everybody the same access to healthcare is quite challenging. We have the government in Norway aims to ensure that everybody, irrespective of their personal finances and where they live, has access to good healthcare service of equal standards. In Norway, we have 18 nurses per 1,000 inhabitants and 5 doctors per 1,000 inhabitants. And nurses in Norway, we have since 1913, and the nursing education has been 3 years, and it's a bachelor's degree. And to become a nurse, you have to take this bachelor's degree, and you get an authorization, and the nurse title is protected. So nobody can call themselves nurses without this bachelor's degree in nursing. In Norway, we have about 5,000 general practitioners doing 16 million consultations per year. Specialist health services does 12.4 million outpatient consultations, and our general practitioners act as gatekeepers for the health and care services. So when Dr. Giali told that the nurse was sending the elderly woman to the hospital, in Norway, the nurse would send the elderly patients to the GP first, and the GP would see if it was necessary to go all the way to the hospital. Norway have a fundamentally good health and care services, and we have early adopter of e-health solutions, and the health and care sector and citizens have good access to digital tools, and we are constantly improving digital skills. But still, as told from New Zealand, we have also had the problem that everything is been working in different silos. So we have decided to have a common strategy for digitalization of the healthcare service in Norway. And the sector strategy that is unifying, and it gives clear direction. And this have been developed through broad involvement of actors in the sector, including patients and user organizations, industry, research, and academia. And this is a strategy that is unifying and normative. And it came into force just last year and is pointing towards 2030. And it shall contribute to realizing overarching political goals and support the health and care sector's needs. It is based on a collected knowledge containing of a current situation analysis and a scenario analysis. And the plan for realization that specifies how the strategy is to be realized and followed up. And it is important to measure progress on goal achievement, otherwise the strategy will not be used. And I put in a link, so if people want to read something more about it, you can read about it later on. But now I will give you one example on how we have been working with remote care. It reminds a lot about the ones that Dr. Gielli was telling about, and Dr. Gielli and I have been talking about this earlier on, but I will take it through very shortly. Our national project on implementing remote care. And we have had scientists following up this project, so we have some results from the research they've been doing as well. The target population for this project is people with chronic diseases such as COPD, diabetes, heart failure, cancer, and mental illnesses. And they have to have comprehensive medical needs with medium to high risk of worsening of their condition, hospitalization, or increased need for health and care services. And also considerable disease burden and comprehensive medical needs, often from different levels of the healthcare services. And of course, they have to be likely to benefit from using this remote care. So from evaluation of the first part of this project, we can see that it has increased safety and improved healthcare. The patients feel more safe and secure. They understand their disease and they cope better. And they tell that they have increased quality of life and stabilized their health condition. And we can also see the mortality rate is lower. And for the municipality, reduced use of home care services. And we used the self-care plan, SCP, and it showed to be a quite useful tool. And we also see that the nurses can supervise several patients. And for the nurse, it's easy to detect deterioration. And we can also see that with working with this, it's improved cooperation between the different sectors in the healthcare system. And for our GPs, they see that it's an increase in consultations due to interdisciplinary meetings to establish self-care plans. And self-care plans makes it easier to involve the patient. And we can see that the patients also are more conscious of their own situation, and this helps improve and help the structure in the dialogue with the GP. And for the hospital, we can see improved cooperation and understanding. And the research showed no effect in hospital admissions, while several patients themselves report reduced admission and less consultations with the GP. And of course, and very important, we can see that it's really an increased interest in cooperation between the hospitals and our municipality services. So In Norway, in recent years, we have moved from specialist healthcare into patient's home through the use of new technology. Video and telephone consultations are funded in the same way as consultations in person. We have more efficient use of human resources in the hospitals, and more types of healthcare personnel, not just doctors, can initiate reimbursements to hospitals, and more ambulant and team-based treatment. Hospitals receive additional reimbursement when healthcare personnel provide treatment outside the hospital, and integrated team and cooperation between service levels. Work has been done to ensure that municipalities can provide certain defined specialist healthcare services on behalf of the hospitals. So as far as we can see by now, this is something that we are really going to continue working on. And I hope that with our strategy, we can remove the silos and work together to continue giving our inhabitants the best care possible, and still can afford to have the universal healthcare coverage that we have in Norway as of today. So thank you.